introducing Saif Abed. Saif Abed is an MD from the United Kingdom, Oxford University, Cambridge University, London University, very well qualified individual, and an advisor to the European Commission and the World Health Organization. He's now a partner with AbedGraham, and he's here today to kick off our first keynote for the day. So Saif, I will hand the mouse to you and let you take away your presentation. Thank you for joining us today, and thank you for sharing your thoughts.
Thank you very much, Richard. I just want to check you can hear me okay and you can see me sharing the screen.
Perfect.
Fantastic. Thank you. Well, I mean, good morning, good afternoon, good evening, wherever you may be in the world. I can certainly say good afternoon from grey London, England, as it is at this moment in time. First, I really need to say it's a real privilege to be able to give this morning's keynote for such a star-studded event with so many leaders, as Richard has already rightly pointed out. So I want to thank him for inviting me to do this. I'd like to thank Cylera as well for hosting the event. Before I introduce myself formally, I just want to say my Twitter handle is @Saif_Abed. So please feel free to tweet at me throughout the course of this event. So I give a lot of talks these days, whether it's keynotes, panel sessions, and increasingly, of course, virtually. And one of the challenges that I want to get out of the way is the whole notion of the title of a keynote talk. As you can see here, we have A Brave New World, Patient Safety, IoT, and Risk Analytics Post-COVID-19. And something I'm very cognizant of is that there doesn't seem to be a day where there isn't some kind of webinar or talk that doesn't have COVID-19 in its title. And speaking as someone with a background as a physician, I can be quite a direct speaker and somewhat of a cynic sometimes. And I feel that sometimes you just simply have to have that in the title, given the state of current affairs globally. But I want to get that out of the way for a very particular reason. For me, I do not view COVID-19 as being a game changer in terms of health IT and security. What I view it as is an accelerant. It's like pouring petrol on a small fire that's become a much larger fire. What it has done is catalyze and accelerate health IT adoption and catalyze and accelerate the level of risk that we're encountering. So everything that I'll discuss from this point onwards, I'm not going to really mention COVID-19. But what you should consider is everything that I'm saying has been magnified by it rather than altered in terms of its sheer content. I think that's a really important point to get across. So just briefly, Richard gave an introduction that was very kind of him to do so. But if you haven't seen my bio, yes, I am a medical doctor by background, trained in London, England. But for the past decade, I've been a partner and director of cybersecurity services at the AbedGraham Group, which is a physician-led global technology group and advisory organization as well. I've been very fortunate to work on national security programs to do with public sector healthcare services, to work extensively with government agencies, healthcare providers and delivery organizations, and some of the world's largest technology companies as well. So the purpose of the talk today is to give you my global viewpoint, my global experience and insights in a way that is universal. Wherever you are as a delegate in today's summit, what I'm going to describe should be applicable to you, or at least be food for thought that you can mull over long after this keynote is done. And that global viewpoint is critical because, yes, I'm based in London, England. Yes, I was here when WannaCry happened, and I've been involved in some major work post that. But I'm also an independent expert advisor on healthcare and cybersecurity for the European Commission, and I've done work extensively across the European Union. I'm one of the people who essentially judges whether a check should be signed after a 3-year healthcare security multinational project delivers its results. I also sit on the digital health roster of experts for the Technology Advisory Group at the World Health Organization, and I'm a high-risk subject matter expert for the UK's Infrastructure and Projects Authority. But actually, the bulk of my work outside of all of that today, especially in terms of technology and analytics, is based in the United States. And towards the end of the talk today, I want to give a sneak peek behind the curtain and a glimpse into some of the risk analytics work that we've been doing at the AbedGraham Group, along with and in partnership with Cylera, because it's very exciting. And I think it would be remiss of me not to share a bit of that with the audience today. So let's take a pause for a moment. Let's not even discuss security and IoT in that much detail. Let's consider the average healthcare organization, whether it's a public sector health system or whether it is a private hospital chain of in the United States, whatever it may be. You have a range of initiatives that are universally being undertaken in different ways. You have your standard EMR, EHR deployment program. You have transitions to cloud-based infrastructure. You have smaller projects centered around e-prescribing, perhaps single sign-on to make life easier for clinicians. Lots of kind of low-hanging fruit projects as well, happening all over the place. For a long time, telemedicine has kind of come and gone in terms of how interesting it is and how much investment has gone into it, but certainly it's been accelerated now during the COVID-19 pandemic. You have much larger programs as well as hospital systems merge together or form consortiums where there's an emphasis on interoperability and integrated care, knitting together a fabric of information sharing so that you can truly have seamless patient-centered care. Many critical elements like that. However, critical to all of this, the two technologies that I really feel have climbed up to the top of the food chain are mobility and IoT. And immediately, we have to get into some kind of discussion of definitions and get into the semantics a little bit. Because what is IoT? In healthcare, it's quite a big umbrella, actually. For a lot of people, it is all about medical devices. For others, they can veer into the world of network infrastructure and servers and appliances and whatnot. For others, it's ancillary IoT. So it's the random smart vending machine or the smart security camera. In reality, I mean, if you simplify it, if you forget that I have any technical background whatsoever, and as a layman, if it's something that wasn't internet connected previously and now it is, it falls in this bucket. And therefore, it is providing its own risk, as Richard was providing in his introduction. Everything is so much more network connected, but not just in the four walls of the hospital. We are now looking at patient-centered care evolving to an extent where it has to be in the community setting, in the family physician office. It's in a physician or a community nurse's car as she visits patients in their homes, or he visits patients in their homes. There are so many different people that I work with, or I used to work with when I was clinically practicing, nurses, radiographers, pharmacists, different types of medics, and they all found that their ways of working, their clinical workflows were altering, not just because of technology, but just because we want to be more patient-centric. And so IoT and mobility is a really interesting jump up in the rankings of technology investment, and the pandemic has accelerated that. But here's the thing. Digital maturity does not equal security maturity. And that might seem like a no-brainer. It might seem really obvious. But you'll perhaps be surprised how often I've been in healthcare organizations across the world where there is an underlying assumption that if we're investing in something newer in terms of technology, by definition, it is more secure. And this comes from a legacy of the last 20 years of trying to convert from paper-based workflows to digital workflows. And in doing so, the assumption is because we become more productive, or so the theory goes, with digital workflows, then we're also becoming more secure. There is also a degree of assumption that we're replacing legacy technology. So by default, we are more secure. And what this means and I've seen this time and time again, is there isn't an equal level of investment in improving the security posture to match the improvement in digital maturity. And, we have a bit of a visualization that describes that. So I call this the healthcare maturity paradox. It's something that I and my team, especially when we're engaging at the board level of healthcare organizations, or even, working with vendors, especially medical device manufacturers, to try and get across the point about maturity levels in healthcare and how they create a level of attractivity, shall we say, if that's even a word, for attackers to target healthcare as a primary area. So the typical journey of a healthcare organization over the past 20 years has been to increase its digital maturity, regulation, legislation, funding, whether that's driven by government or just driven at a board level, has seen a tremendous increase in investment in IT projects that are replacing paper-based workflows for digital workflows and replacing legacy technology for newer types of technology. And every healthcare organization in the world is somewhere on this graph, on this sigmoid curve right now. At some point, the level of digital maturity will plateau. Whether that's a permanent plateau depends. Technology is always evolving, so there's always another step up that can be taken. But in this last 20 years, everyone's on this journey. But here's the thing, security maturity in the vast majority of healthcare organizations, private and public sector, has only seen an incremental increase. And the incremental increase is justified. There is some degree of increase because of the replacement of legacy with newer technologies, for example. But there isn't an outright significant and sustained investment in people, processes, and technology with a focus on the security posture. And that only really seems to alter when an attack happens that affects an organization or an organization's neighbors. Certainly here in the United Kingdom, the WannaCry attack moved cybersecurity right up to the top of the charts, created new funding, new hiring processes, new divisions. But, we have short memories, and the digital maturity side of things continues to be sustained in its investment versus security maturity. And IoT is a huge element of that digital maturity maturation process. And when you look at that gap between digital and security maturity, we call this the attacker's arbitrage. It is that gap that makes a sector attractive. Now this can be applied to any industry in terms of just the sheer academic theory of it. But healthcare is particularly pronounced at this moment in time as having this gap be really obvious to those, to the attackers, to those malicious entities, to those opportunists. Because you have to think to yourself at this point, okay, yes, there is this gap. Well, it means that there's opportunity for successful exploitation for me to meet the outcomes that I desire as an attacker, whatever that may be. So I find that this is a really helpful graphic to get across the point to non-security executive leadership, to analysts that may be involved in the informatics side of the house, but not necessarily so much with security as a top priority. I find it to be a great way to engage with clinical leadership. At the end of the day, a ton of the work that I'm doing is engaging with other clinical leaders to determine what is the best way to progress digital maturity, but while mitigating risk or leaving a level of residual risk that is acceptable. And it's about understanding where the organization is in terms of both its digital and security maturity. And this is a huge challenge right now that's being accelerated and brought to the forefront because of the pandemic. So let's consider the next point. I've just described where an individual organization may be in this spectrum, in this challenge. But now let's take it up a level. Let's go to a slightly more macro level. And please consider this as a model that is again applicable to whether it's a national public sector health system or a private healthcare chain or a group of member hospitals. Typically, you have a structure where you have a central authority agency, whether it's a large hub and spoke model where you have a centralized academic teaching hospital, whether it's a government agency, or whether it's just where executive management happens to base a lot of infrastructure that's fed out to the rest of the the health system. You have a central authority. Typically, this is then surrounded by a suite of different shape and size and service capability acute hospitals. You then have a range of family physician offices and community and outpatient clinic-based capabilities in terms of healthcare service delivery. By extension, you then have mobile healthcare, and I mean that in terms of community nursing, I mean that in terms of community pharmacy. Essentially, you're in particular thinking of nursing staff as they go to see patients with chronic conditions such as chronic wound care, chronic respiratory conditions, seeing these patients in their home and needing access to data that is relevant to enable them to deliver mobile healthcare. And of course, we have emergency services. Now, typically, we find that the central authority, whatever it may be, provides some degree of uniform service infrastructure capability in terms of technology that attempts to be unified across its estate, and also catalyzes, or at least enables, some degree of standardized data sharing, clinical data sharing. You then increasingly see, in order to deliver patient-centered care, you have some degree of emerging interoperability between the primary and community care facilities and acute care. Certainly in nationalized health systems, this is very particular, and I see it evolving in larger health systems, increasingly in the US. As you start getting over the issues of EMR interoperability, you're seeing greater clinical data sharing between individual acute hospitals. And then, of course, all of this information sharing is extending across the emergency services and community health. And what we'll see now, as the COVID-19 pandemic starts to shift from the acute setting to the long-term repercussions into the community, this fabric of healthcare is going to accelerate in its formation in terms of integrated care delivery and interoperability. But what we now have to layer on top of this is the general public. The general public through app-based engagement, prescribed medical devices, remote monitoring, kit, suddenly have a much bigger role to play in terms of the IoT ecosystem and the general engagement that needs to happen moving forward with healthcare providers. And that can manifest in a number of ways, through engagement that's supported and prescribed from a central authority, or that can vary based on delivery from the constituent member organizations of a health system. And that's really interesting, because suddenly you're introducing a different level of risk. It's a level of risk that really you have potentially very little control over. It's hard enough to attempt to manage risk across multiple healthcare organizations in an individual system with so many different stakeholders. Having any semblance of control over the general public is a completely different kettle of fish, you know? And the assumption must be, and this is clearly a major part of zero trust at the end of the day, is that any element of those pathways can and will be compromised. There is always a weakest link, but as we saw with WannaCry, when you have a truly networked system, the right vulnerability with the right exploit can really wreak havoc on an entire health system. And there has to be an assumption, if you don't believe in this model, that at the weakest link in all of this, everyone else has perfect practice that they can isolate the weakest link and the scalable clinical disruption and patient safety risks that the weakest link can create. But we all know that really isn't the case. More often than not, when the weakest link is exploited, it will have severe ramifications across an entire health system. And that is what we need to be cognizant of moving forward. It's no longer about individual harm, it's about scalable harm. And that's something I'm gonna get into, because IoT has simply magnified this model of risk and attack, and the ability to be prepared for it as healthcare security leaders. But I want to drive home a very critical point. And that point is that when we look at the role of the general public, when we look at the role of IoT, we have a smorgasbord, a real evolving mess of interconnectivity that more often than not we are not, as healthcare security leaders, going to have perfect transparency of, and we are not going to have the luxury of creating perfect accountability on every stakeholder in a woven fabric health system, as I describe it. And that is a real challenge. And especially if we consider that in different individual healthcare organizations, let alone when you have multiple organizations within a health system, different stakeholders will have different interpretations of risk and will have different interpretations of what the solutions may be as well. And that is a real risk in and of itself, the people element of this, their behaviors and their interpretations of risk. And very often, I've seen this time and time again, where you have a siloing of the interpretation of risk, say, between general informatics, security leadership, and clinical engineering. They're not speaking a common language necessarily, and they are getting separate streams of funding and undertaking their own initiatives. And now scale that up across multiple organizations in this network fabric. It's a real headache. It's a real headache to resolve. There are solutions, but it's important for me to be candid about that. Relatively lighthearted note, I very much enjoy looking at these real-time attack maps that a lot of different vendors have. I find them quite relaxing, actually, quite soothing. I think this one was from Norse. I don't think they do their active live stream map anymore. There are alternatives, but it's interesting. You watch them, and you see a few attacks bouncing around from different nation states, and then suddenly it just escalates. It goes completely wild in terms of the sheer volume. And I was looking at one of these the other day, and I just thought to myself, if a health system was coming at the end of a sheer volume of attacks, and especially with the rise and adoption of IoT and perhaps the lack of transparency of what IoT is in your estate, it could really be carnage. And my interest isn't in the technical carnage. For me, it's about what does that mean for our ability to deliver safe patient care, to maintain clinical workflow resiliency, to maintain essential services for patients who have time-sensitive interventions required. Should we say stroke patients, for example, require intervention within 3 hours of being symptomatic, for example. There are a lot of different elements there, and that's the perspective I always look at it from. So let's take a pause. What I've done at this point is try to demonstrate for you the fabric as I have seen it globally, as it has evolved in terms of how networked we are becoming, how government policy, how individual health system policies have driven towards that direction in terms of digital maturity, but shall we say left security maturity by the wayside, creating this gap that has made healthcare so attractive to target. But who is targeting them and why and how? Well, I'm just going to keep it simple. First, as we all know, there are opportunistic attackers. Healthcare has gone straight to the top of their list, but their approach to attack really is volume. We want to launch our attacks at as many entities as possible, and a small percentage will succeed, by us spamming our attacks. But that small percentage accumulated, given the sheer volume, is lucrative enough for us. But even the opportunistic attackers, have some sense of strategy, even if it's small. And that sense of strategy is, let's prioritize certain sectors for the highest volume of attacks, because we believe, or we have seen evidence, that those sectors are likely to bite sooner rather than other sectors that could be targeted. So opportunistic attackers are going after healthcare more. And as we know, we as a community of defenders, we have to be correct all the time. The opportunistic attackers need to get it right just once, potentially, to cause a really devastating outcome in terms of clinical service resiliency. That's attack model one. But the one I'm actually more interested in, because when I was at Oxford, I did my research on the impact of cyber warfare on public sector health systems, or really networked health systems. And for me, I saw a really interesting and concerning trend. And that's how targeted attackers are emerging who understand the notion of clinical urgency a lot more. What does that mean? Well, it means that they understand that if I target the most acute capabilities of a health system, access to their EMR, access to their medical imaging systems, to their lab-based systems, then I'm going to hit a workflow bottleneck that is so disruptive that I am more likely to get the outcome that I have desired. And that outcome may be a ransom payment, or it may just be causing disruption. There was an attack in France last year where a ransomware, it was a ransomware attack that claimed for a ransom, but when the ransom was paid, nothing was unlocked. And research is ongoing as to whether the motive of the attack was actually something more sinister, even more sinister, in terms of just purely being disruptive of a safety critical organization. And what I continue to see is that attackers are starting to recognize the importance of clinical urgency. And I coined a phrase for a certain type of attack, but I by no means lay claim completely to the concept, something I call the clinical integrity extortion attack, where I see a future where you do a ransomware attack, but it's not purely on availability, because ransoming on availability, at least you know sooner rather than later that systems aren't available. But what if someone is tampering with the underlying clinical data at scale, mixing together radiology reports across a patient cohort, mixing together DICOM images, mixing together lab results? Let's think of something even more sinister, resetting early warning systems to only report normal results. And as we know, for a significant number of patients, their stats go off before they become symptomatic, so you're delaying care there. It sounds out there, right? But it's definitely an emerging area. And actually some researchers at Ben Gurion University in Israel, they even created a type of malware that was creating fake CT nodules on CT scans. And obviously, it's bits and bytes here, noughts and ones. None of the radiologists could tell the difference either way. Or I think it was something like 95% just reported what they saw, which is perfectly acceptable, but just based on what you see. And this is very insidious. These are very insidious attacks, because everything doesn't just go offline. You're hoping that a clinician picks up on something being off and reporting it, someone technically noticing something wrong in the system and reporting it, or the attacker themselves making the claim on your system early enough that you can intervene. So a lot of interesting points and evolutions in how attackers are progressing, given how attractive healthcare is becoming. And so with all of this in mind, and the increasing number of ransomware attacks on individual hospitals, on entire health systems, we see this notion of executive management saying, cybersecurity needs to step up and come to the big kids table, I suppose. And therein lies a very interesting initial question of, okay, you want to hear from security leadership, but even that by itself, is that correct? Is security leadership something that should be siloed, or should it be a team of the different folks I mentioned before, from clinical engineering, general informatics? Security should be coming together as individual specialized units with clinical leadership to address patient safety. How should this even be delivered? And how can we even judge security and risk in a, shall we say, more holistic, perhaps even sophisticated way that is still something that's actionable immediately moving forward? And this is where I'm going to start discussing a little bit about the work that we've been doing at the AbedGraham group with Cylera. But before I do that, I just want to paint one picture here. I really love one of the things about cybersecurity is how much medical terminology is used in it. When I found myself accidentally becoming a cybersecurity professional all those years ago, I was really worried, because I'm not a technical person by background, but certainly the language made it easier to understand and approach a lot of concepts. And this is one: prevent, detect, respond. In modern medicine, we are very good at looking after people when they are already sick. We respond. Our detection capabilities are okay, depending on what conditions they are, but our prevention is where there's been underinvestment. If we can keep people well in the community, keep them out of hospital, they have better outcomes, and it's cheaper. in cybersecurity, the overall emphasis has been on prevention and prevention by technology rather than people and processes. But that's been shown to be not the strongest model, because without people and processes, there are numerous ways you can penetrate the perimeter of a system and cause all kinds of damage into that soft gooey center, depending on your security posture model. But what we really lack for a long time has been response capabilities. And I don't say that in terms of technical incident response capabilities. There are fantastic leaders that I regularly work with who have some of the best response plans you could think of. But I speak specifically of clinical incident response plans, because in the time between an attack happening and its technical resolution, maybe minutes, it may be hours, and maybe months, that's where harm happens. And so having engagement with clinical leadership about what workflows they resort to maintain safe quality care in that period is critical. And it's something that has to evolve. And so for me and the work that I've really dedicated myself to over the last decade, it's critical that, yes, we increasingly focus on investment in people and processes as well as technology, but context is so important here. We can't silo ourselves purely in looking at technical perspectives of risk, technical attributes of a device, CVSS alone. We have to take everything in terms of its clinical context, because that level of granularity means we can take actions much faster. So just a few final points on this, wrapping up, and I'll hopefully have some time for questions. I'm a real cynic when it comes to trying to put down any cost metrics when it comes to cost of data breach or downtime, unless they come from healthcare providers directly. And one thing we have found from studying a lot of attacks is that the higher the level of clinical disruption that happens as a consequence of attack, generally the higher the costs. So for us, that just underscores the importance of emphasizing clinical disruption. And we found that there's increasing research coming out showing that after cyber attacks on hospitals, they start to experience negative clinical outcomes, poor outcomes for their patients. So that just validates what we've described even more. So the kind of stuff that we've been doing in partnership with Cylera, we've spent the last decade as the AbedGraham group mapping all known clinical workflows in hospital settings in all specialties and their dependencies. We've profiled a huge array of different types of assets that you'll find in a network and their variations. And that means we can start quantifying risks from the perspective of what is the harm that this will cause if exploited to individual patient safety, but also disruption of clinical workflows at scale. This is a huge body of work. It's taken years to come together and form in its own analytics capability. And the way that we've been approaching this recently, working with Cylera, is they do fantastic work generating a lot of technical attribute data about the technical context of endpoints within a healthcare organization. And just as a quick example, let's say you scan a hospital, you find 2 CT scanners, same make and model, they have the same vulnerability that could render them offline. That data goes through our clinical analytics, and what we're able to do is show you a very distinct difference in risk profiles. So for example, the green CT scanner, only one of its kind, found in the east wing of the hospital, but it's next to the ER. It's a 24/7 machine. It's used for traumatic head injury patients, patients suspected of having strokes, patients deteriorating from a medical ward, patients that are deteriorating post-op. You have the orange CT scanner, one of its kind in the West Wing, but it's only used 3 days a week. It's a 9-to-5 machine, only used in outpatients. Immediately, you get a different sense of their risk profile. Within our systems, we have over 90 variations of CT scanners and many, many more contextual clinical workflow variations of every endpoint you can think of. But I just wanted to get across that that level of clinical context is critical for risk assessment moving forward. And it's a huge piece of work we've been doing with Cylera. And the ability to score risk from that clinical perspective is really important. I'm not going to dive into that now, but it's something certainly that I'm happy to take questions on moving forward. And just to sign off, this is my final slide, and I really want to take some Q&A if there's time for it, is that the ability to look at risk And to do it across everything, medical devices, network infrastructure, workstations, random IoT, like, the random vending machine, and to look at it from a automated clinical and technical risk perspective is really so important, because by prioritizing what's going to affect patient safety first, and that's going to affect clinical service resiliency first, we can start taking actions in terms of remediation or active active interventions in a way that's purely based on the business of delivering healthcare. And so that's it for me. I hope that that's been an insightful kickoff to, as I said, a star-studded event of speakers. I'm going to hand back to Richard, and if there is time for any questions, then I'd be more than happy to take some.
Well, thank you very much, Saif. That was very informative, as always. Always love listening to you and presenting with you on stage. And hopefully COVID will allow us to do that in person at some point again in the future. So I'm not booking any flights yet, put it that way.
Neither am I.
In fact, I don't think most people in the US are allowed out of the country at the moment, or at least no other countries are willing to accept us. So that may be a little time. So apologies for that. So thank you for sharing your thoughts there. We do have a few minutes for questions here. If you would like to raise a question with Saif about some of the points he raised, please use the Q&A at the bottom of your screen. And once we receive those, I'll obviously pass those on to Saif, and he can answer those. So please feel free to raise your questions. What is your schedule actually looking like for the rest of the year, Saif? I know that you're involved in a lot of different bodies, but advising different organizations, including the WHO and others. And I spent some of yesterday on a call with Anthony Fauci, Dr. Fauci, here in the US, who was predicting doom and gloom unless we change our evil ways in the United States. So what are your thoughts about what's going on here, and what are your thoughts about the future of this particular space?
Yeah, I mean, in terms of my schedule, it's quite mixed. I'm devoting a lot of my time on the delivery of our analytics platform, as I mentioned, working with Cylera closely as a partner on that. So spending a lot of time actually focused on the US, but I've got quite a few European Commission projects where I'm the senior reviewer. These are really huge multinational projects where you have academia, health systems, private sector consortiums, and I'm in this fortunate, easy position of being the senior reviewer who signs off whether they should receive their funding after 3 years of hard work. So no pressure on me ever on those projects. Doing a lot of speaking events virtually and interviews, and undoubtedly doing some very interesting engagements with healthcare providers around the world, working on their capabilities to manage security risks, but from a clinical perspective in real time. So quite a stacked next few months. In terms of, you made an interesting point. I don't like dwelling on COVID so much because so many people focus on it. But I think, I've run a few informal polls on LinkedIn, and there seems to be a sense, at least from my network, that the investment in telemedicine, the investment in IoT, it's here to stay, it's going to increase. And for the foreseeable future, though, there's this skepticism that the cybersecurity investment is still not going to move at the same rate as the digital maturity investment. And that may be a problem we just have to live with, but we as a community have to figure out the best way to at least pick up that rate for the security maturity curve rather than allowing it to plateau so early. Otherwise, the other key point is we have to invest in leadership. The more we invest in people, the better the results we'll get if we're not having the investment in technology.
Yeah, we've seen a massive rise in telehealth and telemedicine almost overnight, going from 5% utilization to 95% of patients are now being seen by telehealth in many hospital systems. How is the UK, and what are the statistics in the UK, and what is the regulatory framework around telehealth in the public health systems of Europe, for example, compared to our US system?
So it's interesting.
Both, right? So
Yes, yeah, it's very interesting. I mean, number one, there has been an initial large increase in telehealth adoption in the UK. The government issued new procurement frameworks, shortlisted more vendors. We, as the advisory side of the AbedGraham Group, advised a few of those vendors that got selected on those national frameworks. The main thing is, though, that telehealth is really problematic because the regulatory side, there's a regulatory side of just from a healthcare patient data perspective. And then there's the side that's medical device regulation. And those are relatively distinct areas. So in the EU, you have the medical device regulation, and there's a whole that's issued by the European Commission. There's a whole cybersecurity guidance document with that, but that's been delayed by a year in terms of its enforcement because of the pandemic. Clearly, a lot of it was derived from the advisory guidance around cybersecurity and medical devices issued by the FDA. Clearly, a lot of that is advisory in nature, but starting to solidify, I believe, and will become more mandatory in nature over time. So the way regulations have developed, from my view, at least in Europe and the United States, has been very aligned. The one difference I would say is the European Commission has emphasized patient safety and clinical risk assessment more as a part of the cybersecurity document in particular. They've called it out, described it, and tried to emphasize it. And I think they just had the luxury of issuing that guidance after seeing the FDA guidance. So they could find an area to emphasize more. Don't want to get into trade deals and Brexit and whatnot, and what might happen there. But certainly, as a part of trade deals, say between Australia and the European Union, there is going to be there are talks about standardizing healthcare security and patient data regulation. So I think over time, over the next decade, we'll see a global suite of regulations that are more aligned. And there's certainly a number of joint working groups internationally that want to do that kind of standardization.
Yeah, I think you're right. Europe and Australia have implemented a lot of regulations or guidance, should we say, that appears at least to be in front of the more ethereal guidance that's coming out of FDA in the US. And hopefully we'll get to some level of global standardization, particularly around things like patient safety, which the US has tended to trail in. And as you say, patient safety is really the concern, rather than the regulatory slap on the wrist because of a breach of confidentiality, which is where the US has tended to focus. But I think with the expanded threat surface of telehealth and telemedicine, and of course a multitude of healthcare workers working remotely from their homes because they don't need to be on-prem, they don't need to dress in PPE every day to do their jobs, and that has also expanded that threat surface. And I think as security professionals in our hospitals, we need to do a better job of going back and making sure that those emergency provisions that were put in place to facilitate patient care in these trying circumstances, shall we say, need to be revisited and need to reevaluate some of the controls that we have in place before that expanded threat surface is used as an attack, for attacks. So, yeah, interesting times. Sarah, I am not seeing any Q&A in my browser. Are you seeing anything in yours, or Tim?
I am not.
Okay. Well, Saif, you've answered everyone's questions. As always, I must admit, I never come off of a meeting with you feeling that there's much more that I need to ask. So I want to thank you greatly again for your session here today, for sharing your information, and look forward to the next time we get to work together.
Thank you very much.
My pleasure.